All right, ladies and gentlemen, without further ado, let me introduce you to our next guest here, who is, first of all, just a really great guy. I had a chance to talk with him backstage, and I always say, "Hey, what do you want me to say about your bio?" And he said, "Meh, nothing. Just say his name's Andy." And I said, "Well, I probably owe him a little more than that, but I'm glad to see how easygoing you are. So you guys are going to enjoy him a lot." He is a professor at Cal State Fullerton. He's also the co-director of the Center for Sport Performance and the founder and the director of the Biochemistry and Molecular Exercise Physiology Laboratory there. He's a human performance scientist. He's got a PhD in human bioengineerics, energetics, and over 100 peer-reviewed publications and presentations. He's worked with lots of elite athletes. Think all-stars, all-pros, MVP, Cy Young Award winners, Olympic gold medalists. Basically, the top of the top, he's done it, from UFC to Major League Baseball, NBA, PGA, NFL, boxing, the Olympics, even our special forces. They come to this guy because he's a valuable resource in the field of vitality. He is also the co-founder of Vitality Blueprint, Absolute Rest, Biomolecular Athletes, and Rapid Health and Performance. Ladies and gentlemen, please welcome to the stage Dr. Andy Galpin.
Thanks, guys. Appreciate it. I told him not to do all that. He did anyways. Thank you so much. There is the worst time possible one can speak at a conference is right before lunch. The second worst time is right after lunch. You've had some amazing speakers so far. I've enjoyed many of them. I hope to live up to their standards, but I can tell you right now, I'll do this a little bit differently. So my presentation style is a touch odd if you haven't seen it before. A quick note before we get started, I am no longer at Cal State Fullerton. I am actually the director of the Human Performance Center at Parker University. We have a 65,000 square foot facility dedicated to studying and disseminating research on human performance. So a little update to your bio there. As he mentioned very gracefully, I work with tons of professional athletes across the sports at the highest level, and that's really where I've spent most of my time. But before we get into any of this stuff today, like any good scientist, those are my conflicts of interest. I disclosed them, you signed the waiver, we're moving on. All right, good luck. I will talk about a couple of these in brief, but I'm certainly not here to pitch and promote anything I'm doing. But you've been warned. I thought I'd have a little fun given the fact that we are post-lunch and half of you are still on your computers and digesting food and not even back in the room yet. So let's get this party started a little bit here, and I want to play a little bit of a game called 4 Truths and 1 Lie. I'm going to throw some stuff up here, some stuff meaning 5 questions. And I'm going to ask you to tell me which of the 5, which one is the lie, which you know the game here. And whoever can get the most correct, all 5 correct, will get a very special prize at the end directly from me. Are you down? This is going to be a little bit of an honor system, so you got to write down your own answers to yourself. But here you go. I'm not going to read them for you. Here are 4 things that are completely true and 1 that's a lie. There we go. Pretty easy to figure out which one's the lie, right? You guys are at the stage that my students get the first 10 minutes in a day 1 of the semester where they're like, oh shit, I'm never answering a question ever again. Because there's nothing but tricks coming here, right? What do you think? I told you right now, 4 of those are real. Did you know all 4 of those are real, by the way? How many of you think all 5 of those are a lie? They're not. You guys want to learn about them today? That's what we're going to do in the next 55 minutes. Is that cool? Now, they actually told me that I have 55 minutes. I told them I wanted 90, so I'm just going to do 90 anyways. honest reality is I only have time to cover 3 of these in an hour. So either I cover 3 of the 5 or we go 90 minutes. What do you think? All right, sold. What do you think? Just as a shout here. Give me your shout if you think number 1 is the lie. 1, 2, 3. How about 2? How about 3? How about 4? How about 5? Oh my goodness. You guys aren't even close, by the way. You're not even close. This is going to be fun. So that's what I want to do today. That's our outline, if you will. And those are some of the trade secrets that I want to get into. You know, you mentioned the outro. I work with the highest profile, highest paid athletes in the world. And I'm going to do the best I can to share with you all the secrets I got in the next hour or 90 minutes that we get. Capiche? All right, let's rock and roll. I always like to start off with this. This is a daily schedule. Mark did a little cool thing where he told you his schedule yesterday, and I like to do a similar thing. But this is the exact schedule that we put all of our high performers on, down to the minute. It's important that we regulate hormones throughout the day, that we regulate circadian biology, and so on and so forth. And so we are very particular about this schedule, and everybody does the same thing. For various reasons, we have everyone wake up at 7 o'clock in the morning regardless, no matter what. I can explain to you why, but just trust me there. We always start with 2 glasses of water because of hydration. Then we move into what's called a 5-minute body flow to get you up and get you moving. There you go, right? Let's get a little bit of activity. Then we do a 5-minute journal because it's important for mental health and stuff. At that point, we like to take a metric called mood and HRV, and now we're up to 7:15. At that point, they can pee. Didn't have time before that. We got to collect our metrics. You guys know that if you take metrics like HRV and mood pre-getting out of bed, the numbers are different. So we can't pee until we're done with these things. Now we can do our breathing drills because breathing is important. We can eat breakfast at 7:30, not a minute before, not a minute after. We've got to get our 24 minutes in before that. Then you can say hi to your wife and kids, but you can't before. You're going to screw up our metrics. Do not say hi to your children in the morning. Trust me. Stay away. Now you have exactly 4 minutes to respond to all your emails, DMs, and texts on your Twitters and everything else. Now hydration, drink your water. Up to 8 o'clock, we're a little bit behind schedule because you talked to your wife. I told you fucking not to talk to the wife. Okay, fine, we're there. A little bit, pick up the pace a little bit. Now you got to drive to work, find out that you're fired. Oops, sorry. Don't have time, we got to get stuff going. You got a minute to process that because we got to move on. And now we got to get our red light therapy in. And now we can poop after that maybe. And you laugh. I see these things all the time. Right? Like, this is what some people think, oh, pro athletes. Oh yeah, I'm a health person, I'll do all the things. And I see people's programs from coaches. They send them out to people and I'm like, are you insane? How am I going to do all of that? Do I like breathing? Yes. Do I like red light? Sure. Yes. Water? Yes. Meditate? Sure. Yes, it's all great. How am I going to do it all if I'm a human? There's zero chance, if you have nothing else going on in your life, you can fit all of these health practices in. And so the world we're living in is not just give you more stuff to do. You're never going to be effective at all at coaching anyone or yourself for that matter because you're going to look and feel like that. Right? We used to live in a method, and this is like an old science joke that like 3 people will get. But anyone familiar with the TLAR method scientifically? Like a biochemistry thing. It's called the, that looks about right method. Like, you're in the lab, it looks about right. That's the way that I will explain general recommendations, right? So actually, Dr. Patrick was phenomenal in laying an excellent foundation right before. So this works out perfectly. Whoever organized this event, well done. And that's great. General guidelines, sleep more, move more. Yes, totally great. But you end up making people feel like the slide before. Because they're like, all right, I have to do meditation. I have to stretch. And then I'm supposed to see grounding. We need precision is what we need. Right? So it's not that any of these practices aren't amazing. They are. We just have to help people get in a position where they can understand the 1, 2, 3, 4 things that are the most specific for them and their situation for their goal. You feel me on that? Super hard, right? Like, just tell me the thing to do. Like, exercise, move, have great relationships. You're like, oh, fuck. Doesn't help. So this is what I'm going to go after today is the opposite of general. and going after high precision. I call these advanced methodologies. These are things you're not going to find in any other previous talks. You're probably not going to find them most of anywhere else. And I really want you to have a sense of what is coming in the future in this field and how we're moving closer to precision from a scientific as well as practitioner equation. Some of this is based on the stuff we actually are doing now. Some of it I know is coming out soon. But that's what I mean when I say advanced methodologies, is getting after and closer towards precision. So I'm going to make you do a vote right now. I need to know a little bit of who's in the room so I can decide on where to take this talk. Kind of have a little bit of a user choice. If I made you choose between performance as the primary goal of you and your patients in your clinic or whoever you're serving, or longevity, given the fact that we're at a longevity summit, how many of you would pick performance over longevity? How many of you would pick longevity? Great. Remember like 5 minutes ago when I said I was going to trick you? Yeah, I just did. You got to be on your toes up here. These are some of the athletes that I work with, have worked with, and look at that. We're in the Bay Area, so I threw in one of your 49ers. 49er fans in the house? Boo, go Seahawks. To hell with all of you. This is Fred Warner, if you don't know him, probably arguably objectively the best linebacker in the NFL. Lives right up the street, actually, not too far from here. And so while I typically get like typecasted as the guy that works with athletes, I certainly do, but I also do the longevity thing. Any of you know who that guy is? That's Brian Johnson. Love him, hate him, I don't know, I don't care, up to you, you decide. But I also work with people like Brian, and we work with tons of non-athletes. In fact, by numbers, that's more what we do than our professional athletes. And you can actually see this video just came out, I think, where we go over his training program. And so if you want to see that the actual exercise and training program that I do for Brian, you can go check that stuff out. You can go see those things. But I want to play a little bit of a game. I'm going to make you play a game of Brian versus Fred Warner. All right? Now, there's Brian, and there's Fred. And I'm going to throw some stuff on the board, and I want you to tell me, is this a Brian thing or a Fred thing? And some of you are like, I already know where this is going. Let's start off. Has a goal to live to forever and never die. Even if you don't know who Brian is, hopefully the shirt gave that away. I'm a teacher. Got to get you warmed up. I get it, right? Okay, one of these people has a goal of sacking a quarterback a lot. Fred, the other guy. Awesome. We're off to a great start. We're going to tick it up a notch just a little bit. Not too much, just a little tiny bit. Who is interested in having a healthy metabolism? Ooh, VO2 max. Oh, that's definitely an athlete thing, right? Thank you, Rhonda. She taught us that, right? Anyone here not aware of VO2 max is really important for longevity? If you aren't aware of that, you should have been here a couple of hours ago, right? Come on now. See what I'm getting at here, right? Pretty easy. There's nothing I could throw up on those board that is not the same thing I'm doing for both these clients. What is the difference between Fred and Brian? I don't know. One wants to sack a quarterback. Other than that, I don't give any one of these guys like macronutrient nutrition plans. Oh, I didn't see this many calories. Neither one of them is going to be at their best by that. We're at the micronutrient level with their programming for their nutrition. We don't go just, here's some calories. That's not going to go well. We need to know things ahead of time before they happen. Both of them want that, right? You get the point here. Neither one of them needs to be an energy toxicity. We can't have that. We need to be in a perfect balance. Can't be too high or too low. There's just nothing I could throw in there. Nobody got that one? Okay, fine. There's a couple of things that are slightly different between the two of them. But really, it's not that big of a difference, right? And so as I move forward with the talk today, I really hope I can not lose you in the sports thing. Because I know this. I talked to some people yesterday. They're like, oh, what are you talking about? And I started telling them, they're like, oh, sports. And I kind of get the eye roll of like looking for somebody else to talk to because they don't give a shit about sports. Like, I know the room. I know who I'm talking to. Right? I know you saw this in the program. You're like, oh, can we just get a longevity person up after that? I'll skip that session. I don't care about the sports thing, right? When we break down problems, whether I'm going after Brian's program, whether I'm going after Fred's or anybody else's, problem solving is 4 things. And you can see them on the board right now. What I want to do today is show you what we can be doing in 1, 2, 3, and 4, and how this stuff lays itself out. Effectively, number 1, 2, and 3 are just asking the fundamental question of what's the problem. You know the slide I just did before? That was an exercise in me really helping you understand, do we even know the problem? You want better results for your patients. What are you solving? What are we trying to fix in the first place? Before we jump into getting tests done, what are we trying to solve? A lot of people like to jump to number 4. What's the supplement? What's the training program? What's the best sleep thing? I don't know because I don't know what problem we're solving. So we have to go all the way back up to the top and spend way more of your time on 1, 2, and 3 than you do on 4, because honestly, 4 is pretty easy. It's not that complicated once you understand it. So I'm going to give you an example. Rhonda brought up the importance of VO2 max, so let's go through this. Let's say somebody came in and they had a VO2 max of 24 milliliters per kilogram per minute. That's pretty low, but you don't know that yet. You've just assessed it. Data is number 1. Now we have to contextualize it number 2. That's evaluate. Is that good, bad, great, terrible? Well, I can tell you right now, depending on your age, that probably puts you in like the bottom 10th percentile. Okay, so what's the problem? We have our data. Now we know the problem. Now the third step, where should it be? What is a good VO2 max score? I don't know this person, their age, whatever. It's rhetorical right now, but you get the idea. I have to know where I'm going. Let's just say we picked a target of 47 milliliters per kilogram per minute. Okay, great. Now step 4. How do I solve the problem? I don't care. Zone 2, 4x4, hit. I don't care at all. You can get there a million different ways. One of the major problems here is thinking anything on the yellow part is better than the next thing. It's not. We have to identify what problem we're solving, right? If we're trying to improve VO2 max by 2% or 200%, now part 4 changes. You can get improvements in any of those options. Nothing magically better than the other one. The 4x4, great. Everyone lives, awesome. Go do it. Zone 2, okay. Zone 3, I don't care. It all works if you're answering the right question to begin with. You feel me on that one? Okay. So again, 1 through 3 are what's the problem. And so what I want to do now is show you some assessment options that you may not know are out there, some technologies and tools to help you run measurements on any number of things, right? Do you all know, did you realize that we can actually measure environmental pollutants in your mouth with a cell phone app? Those technologies are validated and published. You can see the pictures there. Imagine, any of you ever had your clients do like a food log? They write down what they eat so you can get a basic idea of their nutrition. Everyone done that before? Great. Imagine never having to do that again, because that's automatically measured in an implant in their tooth. You know what the accuracy of questionnaires on food logs are? Yeah, I don't know either, but you know, gone. Because you can actually directly measure it straight in a tooth. We can measure your water quality directly by what water went in your mouth. All this is a very only currently available technology. That is there. It can get even more fun actually from there. You can actually see, they can put these in anything from dental plans to implants. You can put it directly in your tooth. You can put it in as a cap. But this stuff is not super cheap and easy to get now. I don't know, give it 2 years? 5? I don't know, 8? But not 80. That's for sure, right? It's going to be around here sometime very, very, very soon. I always love this one. Look at the braces one. Any of you have teenagers? Any of you have teenage kids? Can you imagine just being like, okay, Stacy, did you drink last night? No. Yes, you did. You had strawberry Boone's Farm, 6.3 ounces. Served at room temperature. Like, oh, my poor daughter. Like, she's toast, right? These things are coming online. This is not something you can go buy right now, candidly. But again, These are published papers. These are not technology pitch decks or anything. These are published papers that I pulled directly from PubMed. So these things are out there. You all know of continuous glucose monitors, right? We can measure sweat or glucose directly via sweat and interstitial fluid now. Did you realize the following is also available? We can measure electrolytes directly in sweat patches. There's a company called NIX, N-I-X. You can put it on people and measure exactly what they're losing in their sweat composition, so you know exactly what to give them in terms of salt. No more wondering how much sodium they should be eating. Just measure it and tell them. That's like $100, by the way. Super, super cheap. I have no ties to them, but it's a great product. Did you all also realize these are available as well? There's probably at least 6 companies that are doing continuous lactate monitors. Ketones, proteins, glutamate, alcohol. Did you guys know this? Talk about change your clinical practice, right? CGM, great, awesome. Now I want to know lactate. Why? You want to figure out sleep problems, look at lactate. You want to figure out if somebody has chronic stress, look at lactate. And look at it in a CGM style, right? CLM. That's available. And by the way, by 2025, those little needles that you have to jam in your arm with the CGM are probably going to be gone. Because they've already validated all of these markers in soft patches, non-needles, clothing directly. In fact, they can embed this directly into fabric. So you can now wear a shirt and get your CGM. For real, I've done it. They can also do it with cameras and lasers. So simple ocular metric shot into a number of different places. Any of you ever seen the Google glasses? Could do a CGM via cameras in your eyeballs. Put on your glasses, we got your CGM. This is not 2030, friends. This is now. Like, these are going to be on the market before the end of the calendar year, many of them, and then a bunch more next year. Read that. Did you know you can do continuous real-time cortisol detection? Do any of you do cortisol testing? Salivary, spit in a tube, go send it out? You certainly know better than to do one, right? So you probably do a nice little cortisol curve throughout the day. Why not just do it continuous? That's available. How about, you want a cycle map, a female? Put it on so we get full hormone throughout the 30 days and really understand what's going on with your cycle. It's ready. Low cost, high temporal, meaning like high speed, high movement stuff. We can do it for antibiotics, we can do it for drugs, so on and so forth. Those are references. These are out. You guys all know this was out? Your world's about to change. Assessment is easy. Did you also know universal wearable biosensors for detecting essential amino acids, vitamins, metabolites, lipids, hormones, and drugs? Can you imagine? Sorry, no offense to anybody in the room who sells testing kits. Here we go, right? Like, we're going to be able to measure these things continuously, pretty easily. You can also do it with lasers. So that's actually showing you right there, if you read that entire thing, you can get hydration, lactate, ethanol, urea, glucose, and more from a laser image, non-invasive, like a camera. This is the medical world you're walking into. This is why when I'm telling you the assessment part, you have to be really, really, really on top of. And what I will tell you in a few minutes is that's not even the long-term value. Because you're going to be inundated and overwhelmed with different assessment options your entire career. This is not a train that will ever slow down. It will swallow you. So we can't put all of our eggs in the basket of only the technology, because you're never going to be able to keep up with the Joneses. You'll never be that. You'll never be able to practice. It'd be super, super, super hard. So what I want to show now is, okay, I could spend the entire 50 minutes on different technologies and tools. You guys ever been into a urinal that has like the little circle thing to make it not smell terrible, you know, kind of like the Target, if you will? They have those now you can put in your home that are continuous lactate or continuous urine collection tools. So no more having to have your people like pee on a patch, dry it all out, put it in the kit, you know what I'm talking about? Put it in their toilet. Same thing can be done for stool as well. That's further down the road, but that's what life is going to look like eventually. And so I could go on options. What I thought I'd do is sort of rein this back a little bit and say, all right, give me an example of how I would kind of use this choosing the right assessment in a couple of different scenarios. So what I want to give you is injury. We get this one a lot. The athletes, of course, but you know what's actually crazy? Most people don't exercise, right? Most general population. You know what the number one reason why people don't exercise is? Okay, maybe not a great answer, but okay. What's the number one reason when you skip a workout? Why? I don't have time, right? What's the number two reason? I hurt. Something hurts. It's going to take me 30 minutes to not hurt, and then I can start working. So it's our number two barrier to entry. So if someone comes and says, I either have an injury right now, or I'm constantly hurt or in pain, what would I measure? And this is exactly what we do when we have clients come in and do this. So this is actually a company called Enable, and this is actually something we put into the San Antonio Spurs billion-dollar brand new facility. What you're seeing there is full real-time kinetics and kinematics on the athlete. You can see angular movements. We can digitize that all, and the athlete's doing nothing. There's no attachment. There's no markers on them. There's nothing. These are just cameras set around the room. So we can run full analysis of that. I know most of you teach basketball, nor do I, by the way. But could you imagine doing something like this in your clinic when someone's constantly coming in for back pain, and you can have them walk across and walk back, and you can automatically see they're in 40% extension? I don't know, but you get the idea, right? So don't worry about the sport side of the equation. Think about the assessment tool as a possibility. If someone comes in and says, I'm hurt all the time, I'm always in pain, you're probably going to start with movement. Do you move poorly? Number one. This is a company called Axial Force. Axial Force allows you to have 3D force plates in the sole of your shoe. What that means is, as they're walking throughout their day, you get a full report back of where you're putting your forces. Oh, it turns out when you're standing, 80% of the time you're putting 80% of the force in your left leg. Now we wonder why we have this back pain or knee pain or whatever the case is, right? They also just got a handful of large grants for this. Now think about this one. Tell me if you can figure this out. Imagine having a force plate in my feet, in my shoes, that I wear my entire life, not as a kid, but as an adult. And a clinician, a neurologist, has those data sent straight to them. What do you think they're looking for? Gait for why? Parkinson's. You can see early onset Parkinson's happening because you'll start seeing shuffling of the feet way before the person starts to realize they have any cognitive function issues. So you're going to have way early detection of any neurological disorder, potentially. They just got the funding for this. But that's the capacity that can happen, right? Your patient didn't have to do anything. They have to show up to the hospital. They don't have to make an appointment, going, I can't remember words, or I'm having... We'll start seeing changes. They'll be subtle, but you'll see that shuffling thing start kicking in potentially years before they even realize it. So from a clinical perspective, again, these things are coming from in sports, but they have a much broader applicability. We use this one all the time. This is called Springbok. This is an MRI. You can do this anywhere you do MRIs. Okay, this is a full body MRI. I don't do medicine. I'm a PhD, not an MD. I don't do cancer. You guys can do cancer, right? We do the other end of the spectrum. So this full body MRI gives you a full three-dimensional model of every muscle on their body, right? So you can look at it and now say, okay, great. Maybe your movement is normal, but your right spinal erector is 40% larger than your left, right? Or your right calf, or who knows what's going on. But you want to look at asymmetry, and now you know exactly what to solve because it wasn't a movement issue. It was a muscle size issue. You get what I'm saying here? You can all do this one. There's no barrier to entry to Springbok. You can just go get them, send your patients to go get them done. They don't have to have a special machine or anything like that. You get your results back in under an hour. You can grab that thing, move it around, do whatever you want, look sagittally, vertically, however you want. You can look at edema. You can look at all kinds of stuff in there, right? So if I'm going back to the injury use case, I'm thinking, was it movement-based? Yes or no? Was there anything going on in muscle asymmetry, especially if this is a chronic injury? Keep pulling my hamstring. Keep hurting my shoulders. What's happening? I want to see, has there been some sort of compensation happen at the whole muscle level? You can also look at this very extensively in blood. right? Now, this is one of the ones, I don't know if y'all realize this, but you can get these directly off of the things you're already measuring. There's over 40 biomarkers highly associated with continuous soft tissue injury, and guess what? Most of them are in a CBC and CMP. Do you realize that? They're right there in front of you. They're right there in front of you on your CBC CMP that almost everybody gets, if you know what you're looking at. The value is not in the assessment technology, friends. The value is always in understanding, interpretation, and analysis. You will get swallowed if you spend all of your time worrying about what technology to bring on board your practice, and you don't spend most of your time understanding parts 2 and 3. What's it mean? What's it matter? Where should it be? Because particularly in blood, there are so many clues right there in front of you if you understand what you're truly looking at in basic panels. We're going to look at sleep, right? You all probably realize there is high associations with long-term health, but there's a strong ties to injuries and concussions, particularly with sleep. Pretty classic study. People have seen this one a lot. What you're seeing on the far left, look at the 6 number, the biggest bar there. Is it working here? You're talking about a 75% chance of injury over the course of 2 years for people who sleep 6 hours per night. I can't tell you how many adults have come into our coaching practice, constantly hurt, and we look at that and we're like, great, I don't need to go any further here. I don't even need to take your blood. I know the answer. Right? I can walk you through the physiology, but it doesn't really functionally matter. But look at how sharply this thing declines. You go from 6 hours a night to 8 hours a night. I can't promise you you'll live longer, but I can certainly promise you your chance of getting hurt are going to get cut in more than half. You're talking about 75% chance down to, look at 8, just over 30. You want to get hurt, train really hard, and don't sleep. It's going to happen, right? 75% chance. Biggest key, longevity, exercise, right? Amazing. You can't exercise if you're hurt all the time. Joints got to stay healthy. Sleeping is a big key to that. You want to see some numbers behind that? There you go. You like the 1.7x? Or you want to take the 61% reduction in injury risk sleeping more from 7 to 8 hours. So again, I can't make an argument that 8 hours will make you live longer if you're already sleeping 7, but I can make a damn good argument that if you're sleeping 7 and you go to 8, you'll get hurt a lot less. A whole lot less. Because of that, you'll train more often, you'll be healthier, and then you'll probably live longer. So I can make that argument. Right? But we're not going to look at sleep in an unsophisticated way. I want to know everything I possibly can about how they're sleeping, why they're sleeping. And so we do this in a very comprehensive way. You can see our system here. This is my company, Absolute Rest, but I won't go into it anymore past this. By the way, I've dropped 2 nuggets already. There were some little Easter eggs I planted in this talk. Anyone pick up the first one? Remember the first 5 questions? Did I answer one already? I already gave one away. I'm going to give the next one away too. We can run a full clinical grade sleep study from your house every night without any wires. My company does it, sure. You want to pick somebody else, don't care, up to you. But you have the ability to do this instead of just sending questionnaires home, which is awesome, good start. But we know sleep is important. People will go on and drone about how important sleep is to their patients. But then they don't give the level of precision and care that they do at their labs. How many blood markers have you ordered? How many stool samples have you ordered? How many full clinical sleep studies have you had? I guarantee that number's a lot lower, right? So we're super caught up in more labs, when we know this trumps the effect anyways. Spend your time there. You know what's crazy? Professional teams, full-time dietitians, multiple doctors, full-time physical therapists, strength coaches, 0 full-time sleep specialists. They're starting to change. They're getting hired nonstop now. But this is a huge wave for performance enhancement, is getting high-fidelity stuff done there. I don't need to explain this point to you. This entire room is here for the most part because you believe in the power of not just measuring what is happening, but why it's happening, right? You want to call this root cause? Sure. You want to call this functional medicine? Great. Integrative medicine. All of you care much more about understanding why something's happening than just covering up symptoms. Am I right there? It's like the entire ethos of this entire room, right? Can we get to the root cause? Can we solve the problem, however malign those terms are? That's the reality, right? We got to do the same thing with sleep. It's not just what does your sleep look like, it is why is it that way. If you do that, you can now solve problems. It's not the assessment, friends. Pick my company, pick another one. I don't give a shit. It's going the next step and figuring out why are you sleeping that way. That's when you're going to start solving sleep problems. We do it a little bit differently, but we're looking at all of these things. We're going to look at not just your sleep architecture, and sure, we can do all that stuff wirelessly, but we're looking at biomarkers, we're looking at blood, we're looking at saliva, we're looking at behavioral assessments. You'll see some ocular brain eye metrics here in a second on the video. Leg movement, bruxism, sure, all that stuff. But we're looking, because what we're really trying to figure out is why are you sleeping that way? Right? That's really what we're going after. One of the things that gets thrown out a lot is like sleep hygiene. And it's for sure very real, right? This is actually from a paper that we have in review. But this is a figure. There's 9 very distinguishable factors that go into sleep environment, right? You know most of them. Light. Don't make it too loud in there. Cold, dark, that whole rigmarole, right? Everyone's kind of like familiar with that stuff. That's awesome. That's great. Don't have pets in your room. How many of you have pets in your room when you sleep? For sure, 2 big old dogs right at the end of my bed. Like, all right. What's the old, like, do as I say, not? You get it, right? Don't violate. Okay, fine. But there's way more interesting things that are in your environment than you realize. How many of you brought a scent, a smell with you from home on this trip? You realize how effective that is at helping your first night sleep stuff, right? You know, first night of sleep, you go to a new hotel room, first night, you never sleep. Bring something that smells from your old bedroom, and you'll dramatically reduce that problem. So it's not just like getting my room dark, it's actually engineering your sleep environment so that it is reproducible if you travel a lot. We have our athletes that travel every other week, right? Or every 3 to 5 days or whatever they're doing. We are constructing their environment at home so that it is modular when we can take a couple of things in a tiny bag when they go on the road and reduce those problems. Can you imagine being a Major League Baseball player? You're sleeping in hotels over half your life, and they're different every 3 to 5 days. You're just going to deal with first night effect? That you're a third of your life, you're going to not sleep because you're in a different room. We have $100 million, $400 million athletes, $600 million athletes. If it's $700 million athlete, like, we're not letting his sleep be bad every third night. When we can solve it by just tinkering and controlling, not just avoiding disease in my bedroom, but optimizing it. Proactively making it as good as possible so we can solve the problem we have. If you don't travel, fine. What other problem are you having? And now engineer this bedroom to make it better. You feel me? Okay. Now, one of the major culprits that I love to talk about in the bedroom that people just ignore are things like dander, pollen, allergens, CO2. These things will completely catapult and destroy, depending on which way you work this, your sleep. Anyone ever had somebody, maybe yourself, who's like, my room is dark, it's cold, I don't have any animals in there, and I'm still struggling with sleep? You ever had that happen to people? Cool. You ever run any environmental analysis in the room? We do. We run that, right? Why? Something is going on in there. You ever have this one? Oh, I wake up in the morning and I sneeze a lot, I'm really congested, and then it like takes a while. You ever hear that one from patients? That doesn't happen for no reason, friends. Right? You know, nose get plugged up. We start mouth breathing, and you know the problems with mouth breathing for sleep, right? It's a really bad idea. Now you're waking up your partner. By the way, you know what? Like the number one cause of sleep disorders in adults that previously didn't have one is children. That was really dry, right? You're like, wait, what? But I'm not kidding. It's not what you think. It's not the joke. A huge number of females develop clinical sleep disorders because of children. And then some women are lucky. Once kids start sleeping the night, they can go back to it. But most will actually not. Most will continue that extremely poor sleep because physiology loves patterns. It recognizes that pattern. It will just continue that pattern. You have to go actively break that pattern. So for females, massive cause of sleep disorders is having children. Men tend to just not have that because they just sleep through everything, right? They just work right past it. And men, you're talking about body size. Like body size for sure is going to cause all those things, right? So you want to make sure you're understanding, again, what's the potential problem? And am I doing something with my assessment, with my measurement, with how I'm asking about their sleep that's really more likely to fix their actual problem? If you're dealing with a man, sleep issues, and you're asking things like, okay, are you waking up? Is your nose bothering you in the morning? Are you snoring? You're going to get nothings. And then you ask the wife, you're going to be like, oh my God. You know how many, we've had so many people come to us because their sleep is a disaster and their sleep is perfect. 100% of their sleep disorders caused by their spouse. Rolling around, moving, so on and so forth. And so we actually end up fixing the sleep partner's problem and their sleep issue goes away completely. I can't even tell you how many times that's happened with us. Right? So we have to ask the right questions. With women, if they've ever had kids, I don't care how old that is, do your best to think, did the sleep problem start with your kids? Like that's always a yes, right? But then did it ever go away? You'll be stunned how many are be like, no, it never went away. You know that's going to happen, so now we can be proactive with women who have kids and putting solutions for them, to them, that they can get going immediately when they have kids so that that problem can go away as quickly as possible. You can do the childing thing however long you want to do that, 6 months, 6 years, I don't care, up to you. But now we can actually get you back to normal sleep once kids are sleeping. That's precision. You call it medicine, I call it coaching. Okay. One of the ones that we see come up really routinely is carbon dioxide. All right. You can see there, I could pull up paper after paper. I don't know if you all can see that, but what you're talking about there is both subjective and objective. Sleep was significantly reduced. Sleep quality is significantly decreased when CO2 levels go up in your bedroom. Positive linear correlation between sleep onset latency, how long it takes you to fall asleep, and negative correlation between slow wave or deep sleep, if you want to think about it like that, and CO2. You won't fall asleep. Your architecture will be messed up. You will feel terrible the next day. But yet we're not measuring CO2 in bedrooms. I mean, we are. Like, we do. But we have things that are right in front of us. You guys know why this happens, by the way? Why does CO2 mess up sleep so bad? I'll give you a little back. You know why we actually had to do this stuff? This all came from the International Space Station. Having to figure out how to keep those people alive up there. And then we started realizing, oh man, once CO2 gets above 900 parts per million, you'll see that actually right here. What happens really commonly? It gets above 900 parts per million, you just start seeing sleep get tanked. I'm being a bit dramatic here, but it's pretty close to the thing. So they had to work really, really careful to keep the International Space Station below 900 parts per million, which you can't open the window, right? Like, good luck. Wouldn't matter if you did. There's no air up there. So then we were able to bring that back down to Earth and be like, well, is the same thing happening in here? And it turns out, yeah, it's a real big problem, right? So why does CO2 mess with your sleep so bad? Y'all do me a favor, real fast. Set your feet flat on the floor. Sit up nice and tall. Don't worry, I'm not going to make you do jumping jacks. To hell with Rhonda Patrick. Okay, cool. Can you do me a big favor? And when I say so, take a giant breath in as big as you can and hold it. 1, 2, 3. Inhale. And hold. And keep holding. So what's happening right now is you are going through metabolism. I don't care if you're using carbs. I don't care if you're using fats for fuel. The end product of all metabolism is ATP, water, and CO2. Now, the feeling some of you are feeling right now is not that your oxygen is running low. You don't need to take a breath in right now. You all know this. You know physiology. You know respiratory drive. What's driving you in that little bit of a panic right now is the increase in CO2, right? If we were to measure your HRV right now, your HRV would be going whoop to the floor. I didn't say breathe yet. I hear people breathing. Laughing? Did you tell them it's okay to breathe? Is that on the screen? I sure as shit didn't say breathe time. Okay, fine, breathe now. I just ruined the whole thing. That's effectively what you're feeling at night. CO2 is elevated in the room. You're rebreathing that CO2. It's not going to be that dramatic, obviously, right? It's effectively called environmental induced sleep apnea. That's what you're doing, right? Now you tell me to fall asleep like that. Go ahead. Sure, you can because you're a psychopath. Right? The rest of you normal people are going to be like, no, I can't. Right? So if we kind of wrap this little case study idea up, what I basically said was, okay, fine. You have somebody who's injured. They're hurt. If they are hurt right now, then ask the question, what is damaged? That's the medicine thing. Get the x-ray, get the MRI, do the eval, do the physical therapist thing. What's wrong? Is it ligament? Is it connective tissue, bone? Fine. But if you want to know why this is constantly happening, now this is the movement dysfunction stuff. This is the micronutrient in the blood. This is the bad sleep, the poor training, the muscle asymmetry, so on and so forth. So pick the right tool for the right question. That all make sense? Catch me on that one? Okay, great. Now, before we go on to our next section and go to the next half of this, I want you to do me another big favor. Can you all stand up? Okay, great. Now, just waiting for everybody to stand up. Okay, now you can sit back down. I didn't say Simon Says. You can sit down. There was literally no point to that. We're 40 minutes in, you kind of need to move yourself a little bit. So those of you who are like, I'm not standing up, you won. You won. I could go on, but you get the idea. This is the assessment stuff, picking the right thing. This is where life really, truly gets hard. Point 2 and 3. How do you evaluate and then know where to go? I opened up the talk by making sure you and I are on the same page. I say sports, I say performance, you say longevity. I don't think we're saying something that's that different. Okay, do we even know where we're trying to go? And now we can finally, at the end, bring in step number 4. But ultimately, honestly, again, that's pretty easy. It's this conversation again, right? Make sure we're in alignment with where we're actually going, what matters, what am I measuring, what am I caring about, what am I striving for? That's 2 and 3, and that part's really hard. So I hope we can end this unnecessary fight between sports and health, right? Now, I'm a little bit bitter, I'm going to be honest with you. Like, the exercise scientists have just been kind of shit on our entire careers, especially from like the medical side of the world, right? It's like, oh, it's sports. So part of this is me being like, girl, like, pay attention to us. Like, come on, doctors, please pay attention to us. But there's also a really good argument I can make where I can say, how much more of the story do you need to see before you believe me? Okay, VO2 max is important, right? Physical fitness and all-cause mortality. You can read that if you want. But you're going to see, yes, Dr. Patrick showed us this earlier. Awesome. You factor in cholesterol, smoking, diabetes, pick your metric. VO2 max will tell you more about your chances of dying or having cancer than any other metric you can pick. But you don't want to know what's crazy about that? Can you do me a favor? Can you see that board? Can you tell me what year that paper was published? 19 what? 19 what? That's 40 years ago. Will you please listen to exercise scientists? For crying out loud. Like, I'm super jazzed. The longevity people are all like VO2, and it's great, and it's on every damn podcast you listen to. We've known this for 35 years. And this is not one paper buried in some library. There are dozens of papers prior to 1992. We've known VO2 max outpredicts almost anything for 35 years. 35 years! It's there. But you know why no one paid attention to it? You know who published that paper? Who's the first author there? Stephen Blair. Exercise scientist. Wasn't medicine, didn't care. Wasn't from Duke, wasn't from Harvard, Stanford, didn't care. Not a medical person, medical people didn't care. 35 years, it finally took him. Now people talk about it. I'm like, great, cool. Welcome to 1990. Good job. I love this one. Like, oh, this person's so advanced. Like, yeah. Every exercise science student from 92 on has been like, yeah, we know that one. We've seen the papers. We had to do a report on it in school. This is one of my mentors, Darren Bishop, PhD. In my graduate program, I actually had to do my physiology in medical school. So I'm in the med school I'm the only PhD in there with all other physicians, and that's great. And he would do this thing, and I'm going to make the exact same joke Mark made yesterday. He used nutrition for the joke. I'll use exercise for the joke. But he would go through a week of diabetes medication, and he would get to the end, and you know the joke I'm going to say, right? Oh, yeah, also, there's one drug that does all of this for no cost, and blah, blah, blah. You know Mark's joke, right? And he would, exercise! He would scream it, and he'd get all animated, right? And he would definitely drop F-bombs. I'm doing my best to not do it myself. And I'm like, yes, we have known this for forever. So VO2 max is this longevity thing. And now people are like, oh my God, you should also not be weak as shit. Amazing. And now there's like health span for strength and be strong. Yo, 1992, that first paper came out on strength predicting longevity. This is not new. I sound super bitter because I am a little bit. Again, I'm the kid in the corner who didn't get the attention he wanted, so I get it. But let's not act like these are giant mysteries of going like, oh gosh, like scientists newly uncovered strength. I literally saw this morning, somebody sent me one. Like, studies suggest stronger people live longer. I'm like, yeah, yes, of course it does. My goodness, right? How about muscle mass? Sure. You want me to pull up the papers on leg power? I can do that too. Like, you already know the answers here, right? Because many of you have heard these things, and many of you are testing grip strength, and hopefully you're testing vertical jump or something like that. But these are just not innovative things. They've been around for forever. So for crying out loud, listen to the exercise scientists. They got some stuff figured out. But we still have to do with a lot of misconceptions in our field. This is a very common graph I hear in the longevity healthosphere thing. You don't want to be under-muscled, but you don't want too much muscle. You see that inverted U? What they're telling you is like, hey, too much muscle actually is detrimental to longevity even after adjusting for muscle mass. And this is unabridged, complete, utter garbage. Completely untrue. Why? Where are these data from? National databases, NHANES databases, Mayo Clinic, Cleveland Clinic databases, right? Are these databases full of super healthy people that you want to be compared to? Most definitely. I don't even have to make this argument to this crowd, right? You literally know exactly what I'm talking about. So this is actually a paper we published. Christy, our doc student, and Dr. Tommy Wood, a neuroscientist at the University of Washington, we published this last year. But we said, fine, you know what? We're going to prove a point. We're going to go into the same database of people. The same database of people, and let's look. Let's look at what these people actually look like. And here's what we found. Strength and physical activity predicting cognitive function. This is not correlation, by the way. We have now mechanism, we have causation. Physical strength will predict cognitive function as you age. You guys catch any more nuggets, by the way? These Easter eggs are coming. But look at the middle of the sentence. But muscle mass does not. Wait a minute. Shouldn't there be a relationship between muscle mass and strength on a population level? The individual person, no, of course, right? Some people can be strong. But on a population level, it's BMI. It works on 100 million people. It's good. It doesn't work on one, but it works on big populations. And so what we found is in those databases, their muscle mass was not associated with their physical activity at all. Which means, how did they get a lot of muscle? They were just being big. They were just big people with a lot of body fat, and some muscle comes along for the ride. So these people in these same databases did not accrue their muscle. They didn't gain their muscle from physical activity. This was not strength training induced muscle growth. This was obesity induced muscle growth. So what's the quality of that muscle? Not good. If you have quality muscle, it looks more, not like VO2 max where that number basically is higher the better. It flattens out at a little bit of a level, but it certainly never goes down. Right? So we still have some correcting to do from our exercise scientists here. And then we have this one, and I can be pretty blunt with that one. I hope none of you are using reference ranges on any of your labs and making informed decisions based on national reference ranges. We already covered this point. It's not the same thing, right? If you want a medical diagnosis, then like that's your all world. You do that, you're medicine, I'm not. But that's not optimal health. You want to know whether or not I technically have diabetes? Cool, you know the cutoff. What's the like, I'm performing at my best? Do you know the reference ranges for that? So all your patients coming in to optimize for longevity, do you know what optimal reference ranges are? If you don't, then we're back to problem square number one. What are we optimizing for? So using a national database reference range, Cleveland Clinic, Mayo, pick your poison, LabCorp, fine, Quest, don't care. Nothing against any of them. But you all know how reference ranges work, right? Reference ranges is 95 percentile. So you will be in the green as long as you're within 95% of other people your age. If you're 2.5% lower, then you're there. If you're 2.5% higher. So like, really? If I'm 93 percentile, I'll be red. But I'm 92.4, I'm green. So like, you don't have diabetes yet. You're just like kind of a little bit diabetic. Good for this crowd, right? That's what you all are after here, right? I just want to like kind of not die yet. It's the opposite of everything you're standing for with longevity, right? You want to live as well and as long as you can, perform at your best. It's not going to be because you were just within inside the reference range. It's in a completely different approach to analyzing anything. VO2 max, labs, whatever it is your specialty, I don't care. But we have to walk. You guys know what I'm talking about. Like I'm preaching to the choir with this one, right? I'm like ranting right now, but I'm getting no response. So either they're like, what is he talking about? Or you're like, oh my God, yes. Like we're already here, right? It's the latter, right? Thank you. Amazing. I'm not going to do this all day, but let's pull up examples, right? Again, I'm cutting the company names out because it's really not about them. There's good reason they do these. It's not their fault. Ferritin, reference range is 30 to 400. Like, what? There is literally a paper titled Optimum Serum Ferritin. Like, you don't have to have my secret database to like just Google optimal ferritin and like pops right up. Below 194. So I don't know. What happens to somebody that comes in not to one of you, but to a normal doctor or to a normal functional medicine person and their ferritin's 420? Yeah, you're a little high. I'm worried about that, doc. It says I'm high. Yeah, but you're not that much higher. You're fine. You know that story, right? You've all heard that story 1,000 times. It's like we're so far past, what? Should I be worried? Yes. I mean, should you go to the ER? No. But do we need to make some changes? Definitely. Well, I'm just a little bit high. Just a little bit dying. Like, I don't want a little bit die. Homocysteine, this is Mayo Clinic, Cleveland Clinic, Cleveland Clinic, if anyone's here. A healthy person, homocysteine 5 to 15. Are you insane? You're 15.2. Don't worry about it. You just have a little bit of dementia risk. Alzheimer's, it's fine. I mean, you're like way past all-cause mortality risk, but it's cool. No chance, right? You can't, I just implore you to not make your clinical decisions based on reference ranges on printed reports, right? C-peptide, super easy ones, awesome. Reference range, up to 4.4, despite the fact that we know over 2.2, we're all kinds of risks going up. Blood glucose, same thing. Reference range up to 99. I get it. 97 is normal, as in common. It's sure as hell not great for your health, though. Now we got to be a little bit careful. Just because you have somebody come into your clinic and they got a fasting glucose of 97, don't freak out. High reactivity with that marker, right? You come in the next day, that might be 84. Like, okay, so understand what things are high variability, what are low, what are, you all know that stuff, right? You cross-reference your blood glucose with HOMAs and HbA1cs and everything else to figure out what's going on, fructosamine and all that stuff. You do all that already. But then you've got the interaction problem. Okay, here's where treating labs and numbers really becomes a problem. Albumin is an acute phase reactant. It's the #1 health marker of anything in biochemistry, in my opinion. The single most important metric, and I bet few of you ever pay attention to it. You know why? Any of you ever seen an albumin number that was off normal? Pretty uncommon though. Why? Here's why. It's an acute phase reactant, meaning if you were slightly dehydrated, albumin is a measure of concentration. So by definition, dehydrated, that concentration number is going to be higher. At the same time, it is reduced with inflammation. So let me tell you this. Anybody happen to go across the street last night to Morton Steakhouse? Maybe you had a glass of champagne. Maybe you had the steak and lobster, and maybe you had the red wine with that. Just saying, maybe you woke up a little bit this morning in your hotel room up here, room 1011, and you were a little bit inflamed, a little bit dehydrated. I mean, I'm just making this up, right? What would your albumin look like? It'd be dead in the middle. It'd be dead in the middle. Right? This is every person who's ever said, how's anything wrong? All your numbers look good, but I feel like shit. I'm trying to stress. Yes, cool, totally thing, but like, there is more information in that thing. We have to understand how these things are working though when we're going to interpret them. Right? So now we're going back and looking at secondary markers, sodium-potassium ratios, DHEA pools, osmolality. Saying, okay, I'm seeing a little bit of dehydration in there. Now I'm looking for some inflammation markers. I'm seeing both those over there. I know albumin is being artificially moved. Albumin is not correct here. Now I'm not going to be transporting cortisol appropriately. It's one of our biggest carriers, right? And now all of a sudden we're working backwards and going, I see what's truly happening here. That's how we properly interpret these numbers, by ditching reference ranges and understanding how physiology actually moves. These are not stagnant numbers. I know I'm preaching to a bunch of MDs, but you just see this routinely. Glance over the labs, MD, everything looks good? You're fine. But there is good news, friends. The world is getting better. This is a really cool paper just got published. But they call this molecular athlete. This is from Mechanisms to Metals. We are getting closer. Don't worry about the word athlete, but we are getting closer to understanding what high performance really looks like from a physiology perspective. What are optimal reference ranges? Where should we be at? These things are coming. They're not publicly available. Dorks like me have these databases, but they are coming out to the masses. I know that in the few years we will start to see and understand, and everyone can have numbers like that. Right? You'll find the top 2 lines everywhere. The bottom line is mine. Right? This is after doing thousands of these things for years and looking at the literature carefully. Right? Starting to really pay attention, again, what is not sick yet versus optimal performance is what you want to do. Now I'll drop you another nugget. Here's an Easter egg. We actually have right now a biomarker directly from blood that comes from 4 markers that are in your CBC and CMP. And we can significantly predict strength, cognitive function, dementia, and mortality from that. So that's a real thing. We have that. We actually validated it against the UK Biobank, 400,000 people. Right? We're talking about an R squared of over 9, over 9.5 actually. And then we can actually predict strength residual. So here's a really fun one. If I know your body size, you can measure this in all your patients. You can actually predict their strength and grip strength, for example, based on body size alone. Now, the difference between their predicted strength and their actual strength is called residual. The bigger that residual, the more trouble they're in. Okay? The bigger that residual, the more trouble they're in. That thing will outpredict biological age or phenotypical age by a landslide. Strength residual tells you a tremendous amount about where they're at. Again, how big are they? What's their predicted strength? Their difference between their predicted and their real, that residual. We can actually get that directly measured from those 4 blood markers as well. So muscle quality from your CBC and CMP is something you're going to actually be able to do really soon. We also validated it against the Ann Haynes database here in the States. And now we've actually taken biopsies, MRIs, ultrasounds, and blood from people in an actual RCT to finish that validation. As soon as that paper is published, that equation will be free to the world. So you will be able in your clinical practice, be able to take their albumin and a couple other markers, plug them into that equation and get all those numbers directly from people, and that will be 100% free. Hopefully it'll be out early next year. The study's almost done, but then you got to publish and do all that stuff. So we went through a painstaking process early in my career where my philosophy was always muscle to gene and everything in between, right? We want to understand and optimize performance. And we did a lot of research at all of these levels. So we've published at the epigenetic level. We've done stuff in monozygous twins with exercise and tissue level organs and things like that. And because of that, we were able to build these systems where we do these really comprehensive analyses, but give them very high precision solutions. And ultimately, that's the goal of what we're trying to get to, is this precision. Now, for you to go out and build this on your own, it's really hard. You have to do all kinds of things like this. This is actually our working model for the most part. We measure everything that goes on or in their body. We measure how that's all metabolized and processed. We measure all the outputs of that. That tells us how they're performing, and that all tells us why they're performing that way. And so with that, we can do extensive testing, high precision solution, and monitor K metrics. But there's a fun future we can end on here. You all can't do that yet. So the future of this thing is what we call the human digital twin. Are any of you familiar with the human digital twin? Oh, you're in whoa. You're in medicine and you don't know about digital twins. Okay, friends. What if we could create a digital twin of every one of your patients, all of their physiology? You can run any simulation on that you wanted, identify exactly the prognosis, effectiveness of the treatment, and then tell them what was going to be the most effective combination of any number of treatments you want. Would that be helpful? You realize that's real. It's one of our other Easter eggs. That's 100% real, and I'll show you. It's extensive. This is 2015, Cell. What they did is a little bit of a version of that, baby version. Take the microbiome, blood, questionnaires, anthropometrics, food diaries, put that into an algorithm, and can I predict glycemic responses based on that? And the answer was clearly yes. Not a single OGGT done there. Not a blood glucose measure. This is 2015. It's been a decade. It's moved on past that. The digital twin market is projected to be $50 billion by 2 years from now. Human digital twin, personalized medicine, and precision healthcare. This is your field, friends. It's not even mine. Building a roadmap towards a human immune system digital twin. That's already been published. Future healthcare, a new era of evidence-based medicine. Just last year, this guy got a $5 million grant in the bottom, or 2022 rather he did, and he launched off that digital twin for the immune system. 5 years. That will be out in 2027. Already started, right? We can now do digital twin for your heart. So we can run a digital twin of your heart, predict which surgery intervention will give you the best outcome, and then that's what you get in the hospital. It's already in use in heart surgery models. You can do this in a handful of different cardiovascular perspectives. I can already do this with your VO2 max protocol. I can put all this stuff in there, figure out which protocol gives you the best results, and then run you through that. This is all over the literature. This isn't Silicon Valley tech stuff hidden in private companies. This is PubMed. This is all over the place. Just Google it around. This is the actual model. That's the human digital twin for the immune system. It's really complicated, but that's the actual working model. And so again, you can take blood, organ, tissue, molecular stuff like I did in my lab for years, run data analysis on that, and now you get diagnosis, prognosis, and optimal therapies. That's pretty dope, huh? Is that what you came here for or what? Like, that's what's up. Cool. We did it too. This is our digital twin. So we can actually take a whole bunch of metrics. I know I'm just a touch over time here, but I'm going to wrap up in a second. They said I got 90 minutes, right? We're fine. Just kidding. Blood, VO2 max, tracker data, your Apple Watch, I don't really care, questionnaires, all that stuff is built into our back end. And here's a nice representation of it. So going back to our injury example that I've been using, you're seeing 3 different athletes. The very first one, you see the far left there, athlete 1. That person, we could predict their injury very, very clearly based on the amount of time he spent running high speed. So that person, guess what we measure and monitor on him? The exact amount of minutes he spends running over 80% velocity during practice. And we actively intervene on that. When he gets past that, that number gets stopped. Because that will tell us his injury. But what about athlete 2? That same exact metric told us a little bit. Athlete number 3 told us nothing. So we don't monitor high running speed in athlete number 3. It doesn't tell us anything. Athlete number 1, it is monitored, it's in the plan, the coaches are aware of it, and there's a hard, sharp pull when he hits those numbers. Right? That's because of digital twin stuff. Now, this is a little bit complicated, but you see those black vertical arrows? Those are actual real injuries, and you can see these data actually go all the way back to like 2017. So we ran historical data on this, and what you're seeing on the single metric is how effective our system was with a single metric. Okay? We're talking about 13% false positive, where our data said he's going to get hurt, and he didn't, right? 13%. And now when we had a second metric and a third metric, now false positive is less than 4%. Right? We know when an injury is coming because we have 4 metrics working together, and the digital twin is going to tell us where his risk factor is at. Okay? So if we go all the way back to the beginning, the reality of it is, friends, human sensors and technology is not going to stop. That's great. Don't let that swirl your head to death. Don't get caught up in hype and buying and chasing, things like that. Right now, we still don't really understand what's good, what's great. I don't know where you should be, but that's actually pretty easy to get us there once we know. So we're struggling on parts 2 and 3, but 1 and 4 are pretty solid, as I mentioned. You want to make yourself get better results for your clients, get as far ahead on point number 2 and 3 as you can. That's a differentiator big time. I've worked with men, women, fat loss, power lifter, world records, young, old, endurance athletes. We've done all of it. And the reason we can have success in all that is not because I know anything about teaching them how to shoot basketballs better or throw punches. But what's the single thing that unites all of them? Physiology is physiology, friends. You want to perform at your highest level, perform at your highest level. You want to use that skill to kick somebody in the face better? Sweet. You want to use it to be a better leader, decision maker, have more energy? Fine, I don't really care. When I think about the word performance and perform, I think of things like this. All right, this is my friend Travis. This is us on stage in Las Vegas, 65,000 people in front of him. He's got a drum and lights and energy, and he's going to sweat over 3 pounds during his concert. He's also almost 50 years old, and right when I took that picture, he had just had a baby. And then he was like, hey, Andy, let's go run a marathon. I was like, what? So he does his tour, has a baby, and then goes and crushes a marathon as an almost 50-year-old. Not an athlete, but that's his performance all ever going to get, right? His wife, Courtney, same thing, but she doesn't want to go run marathons. She's not in front of stage, but she's got to run her company. She's got different things. They're both performing at their highest level. And this is how we're getting them there. So hopefully, I never end up seeing things like this from any of you or any of your patients, where we overwhelm them with nonsense and non-specific things. We can give them much more targeted and precise actions. Which one of our 5 was a lie? Was number 1 true? 2? 3? 4? 5? They were all true. I tricked you. Thank you so much. I really appreciate your time. Enjoy the rest of your day.